Hi, my name is Sukpreet and today I will be talking to you all about breast engorgement with twins for my Nursing 7155 Breastfeeding Theory course. I will use the Situated Clinical Decision-Making Framework in order to outline this case study. Engorgement is a physiological condition in which the supply of milk exceeds the demand of milk, causing the mother's breast to become painfully swollen. It is also characterized by an increased lymph and vascular flow to the breast, which can produce interstitial edema. Engorgement can be classified as either mild, moderate, or severe. Engorgement most commonly occurs when breast milk first comes in at about days 2 to 5 postpartum, although it can occur at any time during lactation. After birth and delivery of the placenta, progesterone and estrogen levels fall and prolactin levels rise. Prolactin produced by the anterior pituitary is responsible for milk production by stimulating mammary gland and duct growth as well as epithelial cell proliferation. Oxytocin produced by the posterior pituitary gland is responsible for milk ejection. It is most commonly stimulated by infant suckling at the breast. Oxytocin causes the myoepithelial cells of the mammary ducts to contract and expel milk from the alveoli. When milk production rapidly increases, milk volume in the breast can exceed storage capacity of the alveoli. When breast milk isn't adequately removed, the milk-secreting cells of the breast overdistend, making them flat. In severe cases, these alveoli can rupture, resulting in partial or full occlusion of capillary blood circulation surrounding the alveoli. Increased fluid in the breast produces swelling and leads to plugged ducts, which further leads to breast infection known as mastitis. Causes of breast engorgement include limited contact between mothers and infants, such as during premature or surgical births, when babies are separated from their moms, leading to delayed initial feeding. Interruptions in breastfeeding can cause the breast not to be emptied as much as usual, such as when the mother cannot nurse or pump as often, when the babies are introduced to solid foods, or when the infants are ill and experience a poor appetite. Milk stasis or accumulation of milk can occur when the infants aren't feeding often or long enough, meaning the breasts aren't being emptied as often or as adequately enough to prevent engorgement. Hyperlactation or high rates of milk synthesis, as seen in mothers of twins, may experience increased milk stasis. One twin feeding more than the other results in one breast emptying more than the other. Incorrect breastfeeding mechanics, including poor latch and poor positioning, can lead to sore and cracked nipples, preventing the mother from wanting to breastfeed. The chances of becoming engorged and developing clogged ducts and mastitis increases when one abruptly stops breastfeeding. Typical signs and symptoms of engorgement include swollen, firm, and painful breasts. In cases of severe engorgement, the breasts become very swollen, hardened, glossy, and warm to the touch. Mothers may report feeling heaviness in their breasts. Flattened nipples and firm areoli are also a common occurrence. Low-grade fever of around 38 degrees Celsius and an overall general malaise may also occur. Mothers may also report slightly swollen and tender lymph nodes in the axillary region. In cases of engorgement, many factors influence the mother-twin triad. The mother may experience negative changes in her body image due to the physical changes associated with engorgement. The infants may experience difficulty latching onto their mother's breast due to the firmness of the areolae and flattening of the nipples, producing sore and cracked nipples. This can cause the mother to experience pain and discomfort, leading her to seek other methods of providing nutrition to her infants. As a result, she may also experience feelings of guilt, which can have negative effects on her feelings toward breastfeeding and motherhood overall. The twins may not receive adequate nutrition due to the impaired latch and being unable to remove milk from the breast effectively, and hence may require supplemental nutrition in the form of hand-expressed or pumped breast milk, pasteurized donor milk, or formula. Using other methods of feeding for the twins may result in a weakened mother-infant relationship due to decreased skin-to-skin contact. Consultations to other healthcare professionals, including public health nurses, breastfeeding clinics, physicians, and lactation consultants, may be required if breastfeeding measures do not improve and if the mother does not experience relief from the symptoms of engorgement. Our 3 priorities for breast engorgement are feeding the infants, moving the milk, and assisting the triad. So feed the infants. We want to ensure that both infants are receiving adequate nutrition. We can do this by increasing duration and frequency of feeds. This will help to ensure that the infants are well fed and also help with milk ejection to relieve engorgement. We can assess this by checking the amount of wet diapers each infant has daily and assessing feeds to ensure that infants are suckling at the breast and that audible sounds can be heard. We also want to promote skin-to-skin contact to promote effective latching as well as to stimulate the release of lactation hormones. We want to move the milk to ensure milk stasis is prevented. The mother can do this by hand expression or pumping milk out of the breast when they feel too full, as well as ensuring that the infants are effectively latching and positioned correctly at the breast. If one infant has a larger appetite, we want to make sure that the mother switches the breast for each infant at each feed so that an equal volume of milk is being ejected. Ultimately, we want to assist the triad by offering guidance and support to ensure that the mother and infants are comfortable while breastfeeding. We want to make sure that the mother maintains her milk supply, as with engorgement, pain and tenderness may cause the mother to feel reluctant in feeding. Stopping breastfeeding, however, can result in milk supply decreasing and not be enough to provide sufficient nutrition to her infants. We can help the mother identify optimal feeding times as well as to look for infant cues of when they are hungry instead of setting a rigid feeding schedule, which can contribute to engorgement. Before breastfeeding, mothers can gently massage their breasts and apply warmth to soften the areolae and the nipples. It is important to apply warmth only for a few minutes as this can increase swelling and inflammation. Mothers can apply cool compresses 20 minutes before feeds. Mothers can also soften the areolae by reverse pressure softening, hand expression, and pumping. During the nursing session, mothers can gently compress and massage the breast to help drain the breast and promote milk ejection. Moms can pump or express milk to relieve discomfort if breasts still feel full after feeds. It is important to ensure they do not express or pump excessively as this will trigger overproduction. Massaging between feeds can help with improving milk flow and reducing engorgement. Cool compresses such as ice packs or gel packs can be helpful. They should be applied for about 15 to 20 minutes after feeds with a 45-minute break between feeds. Cabbage leaf compresses also have been shown to relieve moderate to severe engorgement. Instruct the mother to chill and wash the leaves and apply them to her breasts in between feeds. And to ensure that the mother limits her use of cabbage compresses as they have been shown to decrease milk supply. It is recommended to leave them on for 20 minutes for no more than 3 times per day. Mothers can also take acetaminophen or ibuprofen to help relieve pain and inflammation. Feeding twins can be physically and emotionally challenging for the mother. With proper assistance and guidance, however, she can be successful. She can feed one infant at a time until both are able to latch effectively at the breast or feed the twins simultaneously if she feels comfortable. 3 common positions used to feed infants simultaneously include double clutch, double football hold, cradle clutch combination, or double cradle hold. Help the mother choose which works best for her and her twins. Mothers and twins may be separated at birth, resulting in delayed initial feeding. It is important for the mother to maintain milk supply and effectively remove milk via hand expression or pumping, so it is important for us to provide the mother with information of proper hand expression and pumping techniques. The mother should be allowed to meet her infants as soon as possible and attempt to establish skin-to-skin with her infants. Early contact can promote maternal-infant bonding and thus increasing the prospects of developing an effective latch as well as strengthening the triad. If possible, nurses can allow mothers to room in with their infants if they are placed in the NICU. It is important to provide encouragement and support the mother and help her understand her condition. Educate the mother on recognizing the signs and symptoms of engorgement so she can take the appropriate steps to prevent or relieve reoccurrence. Teach the mother about previously described treatment methods to ensure she'll be aware of them in case of reoccurrence. The mother may also require additional support, so it is important to refer her to either a lactation consultant, physician, public health nurse, or breastfeeding clinic. To evaluate outcomes of care, we want to ensure that we were successful in meeting our top 3 priorities. Are the infants well fed? Is the milk being moved? And is the triad being helped? We also want to evaluate the effectiveness of our interventions. Does the mother feel supported and confident to continue breastfeeding? Have the infants been able to latch effectively? Has the mother identified optimal feeding positions? Has the mother experienced relief of her symptoms? And if not, does she require additional support and guidance, and has she been referred? Is the mother able to recognize the signs and symptoms of engorgement should she experience reoccurrences? And has the mother been able to identify which mode of treatment or which combination has been most effective in relieving her engorgement? Finally, is the mother aware of when to seek medical attention? In conclusion, breast engorgement is defined as a physiological condition which commonly occurs shortly after birth and through the breastfeeding journey, when supply is greater than demand. Mothers of twins can be presented with this condition due to higher milk production and experience special challenges in this case. It's important for mothers to be able to recognize signs and symptoms as well as which treatment methods work effectively for them in order to prevent further complications such as mastitis. Additionally, we can provide support by teaching mothers proper feeding techniques to ensure adequate feeding and that milk is being moved. We can provide assistance to ensure that infants are well fed, that milk is being moved, and the triad is being helped as a whole. We must be able to recognize when mothers may require further support and guidance in order to facilitate recovery and ensure continuity of breastfeeding. Thank you for listening to my presentation.